some stuff, have some confidence talking to the patients and stuff. I made those sheets. I don't know if you guys want to bring them with you, make copies of them or whatever. I was trying to think of common questions.
Can we keep it?
Yeah, totally. Make copies of it, do whatever. So my role, I'm the Stryker Senior Clinical Specialist. Just got moved to senior, so exciting. Is there like a clicker? You want me to stand back here? Good? Okay. So I work for Stryker. I'm the Stryker rep. Senior Clinical Specialist. I'm in the OR for all total joint cases. So a little bit about what I do from the day-to-day. So I'm there pre-op, before the case in the OR, working with the surgeon on the case plan and whatever he's planning for. A lot of the cases we do here are very repetitive, so I do know like kind of what the surgeons are gonna plan for, just looking at x-rays, seeing kind of the deformity and what they're gonna end up doing. So that's kind of just like, we already know that and don't really even have to discuss things some days. In charge of the implants, the instruments, making sure like the surgical tech's ready before the case, has everything, case readiness, all of that stuff. And then intra-op, so I'm guiding the instrumentation, making sure the surgical tech has things put together properly. All the surgeons have different workflows, all the surgeons have different preferences, so I'm making sure that they kind of know what the next step is gonna be and that they have the right things open, like CR versus PS and stuff like that. But I like to call myself just like, I'm the resource in the OR, I'm the resource for anyone, like, if anyone has questions about something that doesn't even involve my job, like I might even know just because I'm in the OR all the time with these guys. So like even at the main hospital, like we do what 60 plus cases a week with the 4 docs. So it's very repetitive and we do know a lot that I don't even know if it's in my job title, so. So this is my little Stryker team. You've probably seen these guys running around too. Jason and Matt are my coworkers. They are the sales reps of the team. I'm more the clinical specialist, but we all kind of do the same thing. So we make sure that everything's kind of ordered. If we have, Dr. Brothers has 5 hips on Friday or whatnot, like we have to make sure we have enough instrumentation for the day. If things are contaminated and whatnot, so making sure we have backups and everything. And even implants, like making sure we have the right inventory. Why this whole thing matters for you guys, obviously help answer patients' questions, improve the workflow of everything within the surgery center, and then just build confidence for you guys in pre-op. All right, so first question of the day is cemented versus cementless. So I don't know if you guys see it or not, or have questions about it. So 3 of our docs do cemented, and I'll get into the surgeon preferences, and then 1 of our docs, so Dr. Kelly, does cementless almost every single time. This is just based on surgeon preference. So basically the difference is...
Is this just for knees, just for hips?
This is just knees. We do, I'll get into the hips. We can do cemented and cementless hips, but we do more cementless hips, so it's kind of the opposite. But basically how we look at this is, with the cemented knees, we are putting cement, so there's your femur. So this is a cemented knee. So you're gonna put this on the bone, but there's gonna be cement in the middle of the implant and then the patient's bone. So that's gonna fixate it onto the patient's leg. Rather cementless, this is a cementless tibia. This has a specific porous finish, so the bone is gonna grow within the implant. So this is mimicking like the cancellous bone. It's 3D printed. It's called titanium. So over here, so there's a titanium finish on cementless implants to allow for that bone to grow within the implant. Rather cemented, that cement is fixating it into the bone. So for Dr. Kelly, for example, so based on surgeon preference, of course, for Dr. Kelly, for example, he will sometimes cement knees, but that's based on like the patient's bone quality. So if the quality of the bone is a little crappy, he's gonna cement it, and he's gonna make, because if it's not gonna grow within the implant, then he's not gonna wanna do it, because we don't want it kinda like not actually stable within the patient. So we can tell the difference between the two. I wish I had a cementless femur with me, but you can just see the finish on like the implants themselves. So we have 3 implants that would be cementless and then 3 that would be cemented, because the poly in the middle is gonna be what it's gliding against. And I can get into that in the next slide. So first we'll go over the total knee replacement. So we have 4 components. So you have your femur, your tibia, and then in between those two components, when you're extending and flexing your knee, you have that femur gliding against your tibial insert. So that's what this plastic piece is. So that's gonna lay on your tibia, and then your femur is gonna glide against that piece. And then the fourth piece is your patella. So as you're bending and extending your leg, that patella is tracking against your femur. So we have 4 components. So you can see the patella trochlear groove on the femur here. That's where your patella is kind of gliding as you're extending and flexing. So your femur here, cobalt chrome, metal. You can tell the patients it's metal. Tibia, tibia here, metal. What's in between these two? Plastic. We're gliding like that. You can see it on these models too. And then your patella, plastic. And then that's going this way. We're gliding like that. So 2 plastic components, 2 metal components.
What clicks when patients complain of clicking?
I would, maybe your patella, depending if the tracking's a little weird.
Okay.
But maybe not. Maybe it's just the clicking of extension and flexion. I don't know. That's more of like a surgeon question, depending on where the clicking is, you know,
Okay.
And how the ligaments are kind of lying.
How long do the plastic pieces last?
Yeah, so if we were to do a revision, so I'll get into kind of like the longevity of everything at the end. We say like 20-ish years, I would say, but it all depends on the type of patient you are. So how active you are, how much stress you're actually putting on the joint and whatnot. But we have manufactured, like, all these companies have manufactured this plastic piece to be like cross-linked is what we call it, X3. So it's so strong, and in any like lab setting or anytime they've tested this material, like it takes so long to actually like wear away. But you'll see patients that like when we have to do revisions, we'll poly swap this. So we'll just take this out and swap a new one back in. And we'll see some like yellow wear on it, but that's just gonna happen over time. So that's cemented, cementless, same type of deal, but we're gonna have that cementless fixation on there, so the titanium finish on it. And you can kind of see it on, if you see the little sharp pointy ones, you can see the finish on that. If you wanna pass this around, I guess. You can see like the porous coating on the bottom.
Mm-hmm.
Yeah, and then Matt Gerard, the PA, he was like, can you tell them that we're not, like a lot of the patients get confused with how much bone we're actually taking off. So I just wanted to let you guys know we are taking like tiniest amount of bone, like we're resurfacing that bone. We're kind of just taking the minimum amount of bone to fix a deformity, and then also just to get the implants in. Because obviously the implants have like, this is 8 millimeters of thickness on the distal part. So we need to take, if there's arthritis, there's kind of bone wear there, so maybe, I think it's 8.5 actually. So we take 8 millimeters of bone off the distal femur. But you know what I'm saying? Like we're just taking the least amount of bone we can, because we're not trying to take the whole patient's leg out.
We had a patient once that said before surgery they weighed 100 pounds. After surgery they weighed like 105. Are you right?
That's
And then they were like very concerned, and I think they had fluid gain. I don't think, but like the joint is typically the same as what, like you're not leaving here weighing 10 more pounds after a replacement.
No, I mean, you can feel these. They're definitely not like light. You know what I'm saying? So I can see maybe a little bit. Like I don't know the exact weight of these, but
So
we are
slight
taking
gain is
some
normal.
bone. Yeah, slight
Okay.
gain. But like for revision scenarios, when we're taking, like say they have a distal femoral like whole fracture here, and we're taking the whole femur off and replacing with this huge metal piece, like that's definitely heavy. These are like, we're taking bone to kind of like, this is super light. The femur and the tibia are metal, so it's kind of, I can see maybe a couple pounds,
Okay.
I would say. And like you were saying, I don't know if you guys even have to deal with like the difference, or if the patients even know PS versus CR. But basically there's 2 types of knee systems that we use here at the surgery center. And this is just for like a primary knee replacement. So there's PSCR, so posterior stabilizing, that's when the surgeon takes out the PCL. So then the implants are actually kind of taking place for that stability. So here's the two like plastic pieces in the middle. So this is PS, so it has a little post in the middle, basically taking place of the PCL that we already took out. This is CR. So basically all the guys do PS, and then CR Dr. Brothers does. And Dr. O'Sullivan used, I don't know.
What's the benefit of the difference?
Surgeon preference. I think CR is growing. I'm obviously like younger and like new with the technology growing, but we do see a lot of CRs like out at other hospitals a lot more. Dr. Lehman's obviously doesn't change much, so he's always done cemented PS. I think he makes a lot more releases, so he does get like a lot more exposure to the knee as well. Yeah, just more stability. Like the PS gives you more stability. So like if Dr. Brothers has a really bad deformity on that knee, so say it's super valgus, like then he needs to take a little bit more bone and he needs more stability within the knee, he'll convert to the PS. And then also because of this post in the middle of the plastic, like the femur, we take that notch out. So we'll have to put this on here. So that I'm on the wrong way. See how that slides there? It doesn't allow like the tibia to slide.
So do you have less range of motion with that?
A little bit less range of motion, yeah. And then obviously the grooves are a little bit deeper. But yeah, so we have to take the notch out, so the box prep. That's where we take the notch out in the middle of the femur. So that just comes with prepping the bone. So with a CR, you won't need to prep that little box out for the insert. And yeah, we just put the knee ligaments on there. Obviously your PCL is posterior, so that posterior ligament. And then we are cutting out the ACL. We're leaving the LCL and the MCL. So I think some patients might ask that. Taking out your ACL, taking out the whole meniscus, we're resurfacing that whole tibia and that whole femur basically. And then PCL is optional. So ACL, meniscus is out. Surgeon preferences, like I said, all of them are basically cementing. Dr. Brothers is the only one CR. I did want to go over like Dr. Lehman. I know he uses navigation, which might raise some questions. So he does PS cemented, and then this navigation machine, I don't know, some of you have been in the OR with me. Basically, he uses this for the other guys. So we use our distal femoral cut. That's just one flat cut, basically right on the femur. We use instrumentation to get the angulation of that cutting block and like the amount we're resecting of the bone. We use instrumentation for the other three guys. He uses the navigation machine, so he just puts like a tracker on the femur, and he can see via like the screen how much bone he's taking, what's the angle of like varus valgus of that cutting block, and kind of like the flexion angle of it. So he can kind of manipulate it with a screwdriver, rather we're using exact instrumentation to go up the IM canal, if that makes any sense. So he's just using like technology for that one cut, rather the other guys are using instrumentation. And then Dr. Lehman, for the rest of the procedure, we make a couple more cuts other than that distal femur. He's using just the instrumentation that we have as well, so it's all the same. Since I added a navigation picture, I had to add pictures for the other guys. So Dr. Kelly, I did 25-minute timer because he does cementless, so it takes about 18 minutes for that cement to harden. So his cases are way quicker, and he's typically always doing cementless over here. So his tourniquet time's like 25 minutes. Obviously give or take the size of the patient. But yeah, he's very fast. And then Dr. Brothers, I did like an efficient, like he's the most efficient surgeon I have ever worked with. He has a reason for why he does every step he does. Has a whole workflow in his head. He's awesome. And then Dr. O'Sullivan, I did a picture for adaptable. Anything that's thrown at him, he's willing to make a change to figure it out. Yeah. Any questions there? And again, I don't know if you guys really deal with CR versus PS, but. Okay, now we're working with our total hip stuff. So yeah, we can pass around the total knee stuff. We'll do one of these. Mr. Patella. Go with one component. So obviously your knee is like a hinge joint. But it's not just like a basic hinge, like there's so much like movement that we can manipulate our knee in, so it's not just like a basic that. So that's where it's like it can get very complex. So we can move on to our total hip. So basically that's our ball and socket joint. We do have 4 components with this as well. If we do screws, it might be like 5 or 6. Dr. Kelly always does screws, so he has more. So again, these components are metal and plastic, and then the one difference with the hip is we have a ceramic head. So in the past there was metal heads, and that caused a lot of metallosis is what we called it. It was like metal on metal. So if this was metal, the plastic in here is wearing away, then it'd be metal on metal with the cup here. But I can go over the 4 components. So the first 2 is our acid. So I think of hip replacements in 2 steps. So the first half is our acetabulum, and then the second half is our femur. So first we'll make our femoral neck cut, take out the whole femoral head, which you guys probably know. We'll ream out the acetabulum and we'll insert this cup. So this cup is cementless. So it has that porous finish on it, the 3D printed on here, so bone will grow right in here. And we'll get that stuck right in that acetabulum to the correct size, so this size varies. And then after that, we'll put in this polyethylene, the plastic liner, and that'll lock right in here. This one's not gonna lock because they're 2 different sizes. And then once we do that and have the correct angulation of our cup, so that's super important with dislocating. We want our cup at like, not that you guys need to know this, but like a certain abduction angle and then a version angle. So just how open it is in the front. We want to mimic the actual like native pelvis of that patient. But everyone's basically around the same kind of degreeage of abduction and version. So yeah, so metal. So for the cup is titanium. For the liner, we have the plastic polyethylene. So this is the same X3 cross-linked hard plastic, so won't wear too much over time. Our stem, titanium. We do have like that porous, so we use cementless stems. There are cemented stems, but we do not use them. That only if it's like a 98-year-old person and we're over there, like over at the main hospital. So if their bone quality is very bad. So this is that porous coating, or that separate coating to help with bone growth there. And then we have the head that locks right on, I'm not gonna put it so it can stay separate, but it would lock right on there. And that's your ceramic head, and you can feel how like actually strong it is. You can pass these around.
So you dig out to put the stem in.
Goes into the.
Yes, so I should have wrote this. So once we do that cup, then we'll get exposure to the femur.
That's why they are in
So,
pain.
yeah, we'll get exposure to the femur, and then we have little brooches, which are like, they're kind of sharp. They're the same shape of that, but they're sharper. So they have little like sharp teeth. So we'll go down with a size 0, 1, 2, 3, 4. I think that's a 7 maybe. So they'll keep going
That's
up.
big.
Yeah, that's pretty big.
Okay.
So they'll go up to like get that rotational stability and make sure it's like fixated right into that cortical bone. Because the cancellous bone right in the middle of the canal is very soft, so they can feel it as they're broaching, like, okay, this is going down, this is going down, okay, this one's getting like, and you can also, there's like a high pitched noise you can hear too. But yeah, once they broach and they get to a 6, we'll trial the neck, and there's different lengths we can do in the head, different angles we can do on the neck, and there's a lot of different manipulations we can get to get the patient stable. And yeah, then we'll open the implants and we'll reduce the hip back in place.
You go size dependent on x-ray, so you already pre-choose a size?
So some of them template, some of them don't. So actually all 3 of them template, except Dr. O'Sullivan recently does not template his hips because he feels like he gets, whatever he's templated, he feels like he ends up doing with what feels right. Like clinically, you want to do what the patient feels right in that time. You know what I'm saying? But templating for the other guys gives them like a good sense of like what we're getting to. So Dr. Brothers does take, and I'll get into it, he does take like intra-op x-rays so he can actually see exactly where the implants or the like trials that we're using with the brooch and the trials are actually sitting within the patient's bone. So he can see how close he is to kind of like that cortical bone, just like the white on the outsides, and whatnot. And then he can also look, and I'll get into it in a little while, like the hip length and stuff.
And anterior, posterior doesn't matter, you do the same equipment.
Same equipment, Yep. And then, so with that cementless cup that I was first talking about in the acetabulum, it does have that porous finish on it for the bone to grow in. Sometimes like that won't stick. The patient's bone might be a little worse than most. So Dr. Kelly always does one screw. So there's little holes in the cup and you can just do like a little drill bit through and see how deep it gets. And then we just do a little screw to get that fixation for the cup because we don't want that moving. We want bone to grow within it.
Does that cause more postoperative pain?
The screw? I wouldn't say so.
Okay.
I don't know if that's like truly studied, but probably somewhere. Yeah, so we do all cementless hips at Bosk because we're all young, active, healthy patients here.
Excuse me.
So direct anterior versus posterior, basically the difference, like these are just like kind of preferences for the surgeons. The outcomes are the same, just like we were saying. Direct anterior incision in the front of the hip, posterior incision through the glutes. Muscle, so the benefits of an anterior, it's muscle sparing. So basically, you don't need to cut through any muscles. Dr. Brothers is kind of just moving muscles aside, rather than the posterior, you're kind of cutting through that butt muscle. But the benefit, I would say posterior lateral is more common. It's more of the traditional way to do things. Direct anterior is more of like the growing technology or like the growing reason for why patients are, or why surgeons are doing it. Often anterior is smaller incision. With the posterior lateral, like since you're cutting through that, you have way more exposure so you can see way more. So none of those guys who do posterior lateral take intra-op x-rays. Dr. Kelly occasionally will, but like they can see everything way better than the smaller incision front anterior approach. So Dr. Brothers will do intra-op x-rays, which I'll get into too, so he can see everything. I don't know if patients will ever ask like, well, like if why can't I get an anterior? Like Dr. Brothers will kind of turn down some patients just based on like size, how complex their like anatomy is and whatnot. But basically like you want average thin body types for an anterior approach because I mean, I don't actually know the true reason, but I know getting exposure there is pretty difficult. So you need to kind of.
So obesity is kind of an off the limit.
Yes.
Okay.
Yep. Any questions? We're good?
Is that his only like kind of non-negotiable, I guess? Or is there any other reasons as to why he wouldn't do an anterior?
We don't ever know that he says no, so that's why this is like new to us.
I don't
Like,
know
we
how
only see the
often
yeses.
He does, but like, and he is so, since he is like the only person that does direct anterior in this area, his like amount, like his schedule I feel like is booked out so far, so it's so common. And like also to think about like how you're laying on the table, like some people thinking about, I'm going in for hip surgery, I'd rather be laying on my back, so they're on the HANA table, so they're laying supine, rather a patient laying on their side. So I'm getting my right hip done, I'm gonna be laying on my left leg. So a lot of like, I feel like patients like are more comfortable just laying on their back too. But yeah, I don't know how many patients he actually says no to, but I can totally, like he definitely does do that. So yeah, just like we were saying, Dr. Brothers with direct anterior, he takes the intra-op x-rays and the patient is supine. So he uses like a system, so he'll take an intra-op x-ray and then he uses a thing called RadLink. He pulls up the x-ray on the screen, sterile screen, we have a drape over it, and he can touch it and put the exact, and see the exact angulations and everything of how the cup is seated, kind of the leg length. So we're looking, so when he takes like an AP pelvis shot, which is kind of like what this is, there's lesser trochanters here, like he can look at the leg length based on the other side, just based on this AP pelvis x-ray. So that's like a huge thing with hip replacements. You don't want to lengthen them too much. Like you don't want them coming out with too long of a leg, but you want them to like match the other side or kind of do what they're like the length at which they were due like before they came in, basically. So kind of finding that happy middle. And yeah, so Lehman, Kelly, and O'Sullivan posterior. This is an example of kind of like the instrumentation that we use for them to position the reamer or the cup. What's a cup? What's a reamer? Whatever. To position your exact like cup in that patient's acetabulum perfectly. So we have like a little, you can't even see it. It's like a cross like this up top on the impactor. You line it up with the patient's back and you can see exactly, like it's matched exactly what like 20 degrees of version is, and then 45 degrees of abduction. So that's just one of like a cool instrument that we do use. Rather, Dr. Brothers can look at it and like see, he can't really see on this picture, but he can see the actual degreeage of the cup based on his rad link. Yes, any questions? Good. Lifespan, I just put 15 to 25-ish years. Obviously there's a lot of factors that go into that. So if say you're super old and you get surgery and then, I hate to bring this up, but like pass away, like obviously we don't know actually how much time it would have lasted in you. So obviously if you're younger and get a surgery and it could last 25 years or whatnot. So it's kind of like hard to say an exact time. Activity level, how much, like, are you still running? Are you still kind of active doing sports, skiing, whatever? A lot of these patients get back into doing that, but some of them are just couch potatoes, so you never know how long it's gonna last. Obviously weight, some more stress in the implants is gonna wear it down faster over time, bone quality, and then implant positioning. So say the implant's positioned and it's wearing down more on the lateral side or whatnot, then we still have to do like a revision. And then, like I said, the improved materials and techniques are allowing these procedures to last even longer. So like Dr. Brothers has some weird stat on the polyethylene, how much force it takes and how long it takes to wear down over time. I don't even know what it is, but he's very into that. So it is very strong. Anything that's like clinically tested or like in a lab, it's not supposed to wear down like at all, but that's and then yes, so anything, this slide I also want to talk about kind of like revisions. So like over at the other hospital we'll deal with revisions, here we kind of won't. So like that poly wearing away, so same with the hip poly, it's the same material, that surface in between the metal on metal, or the metal on top and bottom. These will wear away, or like say this thickness kind of varies too. So depending how much bone we take, what their deformity is like. This one's thicker than this one. This is probably like a 9mm, this is maybe a 13. I don't know, it says it somewhere on here. Sometimes like we'll underestimate, like obviously they have a tourniquet on, they're asleep, like we assess the range of motion, but sometimes they might need a little bit more like stability in there, a little thicker of a poly. So sometimes we'll go and have revisions like that, nice and easy. This locks right into the tibia, this isn't the right size. But you'll just pop it out, put it right back in. The metal components are, if they're cemented in or cementless, whatever, but they're sticking in the bone. That's when the real revisions come. So like say you have like a fracture, your distal femoral fracture, and it's above your actual like femur. Like sometimes you just have to like completely cut off your distal femur and kind of replace that whole structure. Or sometimes they're just unstable and we have to take out everything. Like those procedures get super complex. They're super exciting for us because it's different.
How soon after original surgery do you go in and revise?
Depends. So this should never really wear away, but they say 15 to 25 years. But going in for a poly exchange, I would say like 20 years.
Okay.
But probably, it could even be longer. Just depends on the patient and kind of like how their biomechanics work with the implant.
What if you didn't give me a thick enough one? Can I go in next week and get it revised?
Yeah.
Okay.
What's the recovery like just on a revision? I'm assuming it's like
Probably
a lot
way
easier
more.
than.
The recovery, it's probably way more like harder. It's definitely like we're doing way more trauma to like the joint, I feel like. So I feel like it's definitely like.
Just for the poly, the exchange of the poly?
Oh, that definitely
Yes.
easier than a whole
Oh,
revision.
okay.
Or
I'm
a
like,
whole
God.
replacement.
I literally saw the confusion between the two.
I was like, oh my god. But if we're taking, this has cement on it, it's sterilized, promise. But like, if we're taking all, like this is cemented into your bone and we have to take this out. Say like we need to take more bone or like the angle of it or something like.
The 20-year revision is
Yes.
extreme.
Yeah, 25, I would say it's more extreme. But taking all this out, like we're chiseling away for like an hour at these implants. Like the hardest part about a revision is getting the implants out. It's like takes so long, because you don't want to just take away bone, you know, like take away necessary bone. And then we have to go back in and kind of reassess how much bone loss we have and replace it all and kind of get the joint back and moving and mobile and what they came in with. I think I covered everything I want to talk about. Yeah, my biggest takeaways, I guess, are like all these docs are doing different techniques, they have their own preferences, but at the end of the day, we're doing the same goal, so the same 4 main components that go into a knee replacement and hip replacement. And then the surgeon preferences, they all obviously went to different medical schools, different fellowships, different residencies, so they all have their different ways of thinking. You'll see Dr. O'Sullivan and Dr. Lehman start doing like similar things just because they've discussed things. But they all have their different like ways of thinking, and they all read their own article, or like Dr. Brothers is very like study focused, so like he'll read like a study and like that'll change kind of things of how we, or ways of doing things. And then he also has, Dr. Brothers' brother is like the same exact surgeon down in like North Carolina or South Carolina, I think Myrtle Beach maybe. So he talks with him a lot, so when he makes changes, like it's based on like what his brother has to say. And then yeah, just use me, I'm your resource. I can answer as many questions as you guys have if I know the answers, but yeah.
Can you talk a little bit about position to do a hip? Do you dislocate the current hip to get access, and then brothers versus the others? Because like sometimes his patients will have groin pain on the non-operative side, which I think is because of the bed.
Dr. Brothers will have?
His patients seem to have opposite, like non-surgical side hip discomfort
I don't know what
or
that is.
groin, I should say.
Yeah. So for the first step that we do is we take that neck cut. So let me go back to this slide. We take that femoral neck cut, we take the whole femoral head out. Oops. So we're kind of cutting it right here where that brooch is going down, taking the whole femoral head out. And, well, we need to dislocate it first, but yes. Kind of how they dislocate though, like, is very similar. Like they all have to kind of hold traction to the leg and get it out of that acetabulum. Do you know what I'm saying? In whatever way, I think they, like for Dr. Brothers, he kind of pulls it. I'm trying to think of the exact like angulation at which the leg is at. I think it's very similar to how they dislocate both times and reduce it. So Dr. Brother, since he's anterior, he's gonna go more anterior to reduce it back in. Rather the other guys would probably go posterior. But yeah, I don't know.
But they literally dislocate to then make their first incisions.
They dislocate it while they're already in.
They get exposure.
Yeah.
Dislocate, and then they start cutting like the head off and everything.
I got you.
Because the patients are fully relaxed, it's not hard to do.
The biggest thing is like pulling traction and getting it to like slide out of the acetabulum. But yeah.
With knees, you don't have to do anything like that.
No, Dr. Lehman definitely like brings the tibia out a little bit more. So he'll use the retractor and like go on the back of the knee and kind of push the tibia out to get more exposure to the tibia before he makes his tibial cut. But he definitely makes like a little bit more releases than the other guys. And yeah, obviously if you're doing that, because you don't want to dislocate and reduce the hip too many times, because you want them to kind of bring that native hip or a native knee back to life. You don't want to super manipulate it. Yeah, does that make sense?
Yeah.
Okay. Yeah, that's all. That was all I got. Takeaways. And then thank you.
Can you tell if these are your implants?
Yes. Yes, that's cementless and that's cemented.
So he cemented my right one?
Is that you?
Revision,
Yeah.
yeah.
This is you?
This is him.
This is cemented and that's cementless. So,
I was wondering why the thickness.
yeah, you can see.
My right knee is a revision. I had a partial.
You had a partial to a total. So yeah, so
So he did me over at the hospital.
who did it?
Dr. Kelly. He did
Who
both
was
my
Dr.
knees.
Kelly?